It is really lovely to be amongst such a huge crowd, because normally the SMAC organising committee put me off in a side room somewhere for all the weird talks, in a concurrent, there's usually about 7 chairs in there, so this is really nice for me to be sort of allowed out. So thanks for that. But so as not to disappoint you too much, I'd like to start my talk with a little vignette from David Foster Wallace, the great and tragically late writer who wrote novels which were sort of dense and impenetrable, but whose essays were light and sparkling with wit and wisdom. And he wrote one called Consider the Lobster. In this essay, he was commissioned by Gourmet Traveller to write an essay about the Maine Lobster Festival. And he writes so well, so beautifully. You could see the sunshine dancing on the yachty harbour. You could just about taste the melted butter from the freshly cooked lobster, smell the spritz of the lemon. But then fairly quickly, the essay turned, and you got to see these Disneyland-grade queues of sweating, jostling, overweight people who were watching live lobsters being plunged into a boiling pot in front of them. And really what the essay turned out to be about was, is it right and moral to boil sentient creatures alive for our own gluttonous pleasure? Do these simple animals feel pain? But as interesting as that neurobiological argument is, really what I wanted you to take away from this is I want you to just hold 2 things in your head whilst I speak. And one of them is that sometimes the main learning point of an essay or a talk is somewhere hidden off in the shadows, somewhere off-piste in the periphery. And number 2 is the image of a lobster. But let's get clinical. I'd like to tell you about a case that I saw not too long ago. I'll set the scene for you. I'm the duty consultant on, it's close to midnight. I get a phone call. It's from a peripheral hospital about 60 k's away or something. They've got out there a 72-year-old farmer. He's had a big anterior infarct, and they've quite rightly, because of the time and the distance, they've quite rightly thrombolyzed him. It's all good, his chest pain's settling, his ST segments are coming down, and I say, send him on to us, we'd love to have him. And then a few minutes later, I get another phone call, quite panicked, and this has happened. Massive haematemesis, red. Now, say what you like about us emergency physicians, and I expect you all probably do when we're not listening, but when things become unexpected and messy, that is our bread and butter. So I said, I know how to reverse the effects of thrombolysis. I know not much works, but what we do is we throw the kitchen sink at them. So I get them on the path, and unfortunately they've only got the tepid water of the kitchen sink, the FFP, but they say just give it and send them on down, and I'll have everything ready for you. Don't you worry, it'll all be good. And as I'm waiting for this patient to come down, I look at his name, and all of a sudden I realise that he's a very, very dear old friend of mine that I haven't seen for a long time. And I don't know about you, but when you know someone, you start to sort of second guess yourself, and you think, oh God. And I think, actually throwing the kitchen sink, that sounds terrible. Do I really know what the really best treatment is? And I also thought, oh my God, am I going to make him reclot again if I start pouring stuff in? I thought, I don't know the answers as well as I thought I knew the answers. So I'm madly Googling away, looking for stuff online, looking for guidelines, anything else, and I come up with nothing. And that was terrible. So I'm there, oh God, this is bad. And so I ring the haematologist on call to get their advice. And it's the haematology registrar. And they say, oh, Christ, ring the emergency physician. I'm there, oh, thanks, that's me. Anyway, the patient gets here, and luckily the patient does fine. I had the gastros there, it was fine, he did okay. But then I thought, this is not good. This is not good. This is a big knowledge hole, reversing the effects of thrombolysis. I'm not happy here. So I did a very scientific study. I'm glad to hear all the research, but they'll be very proud of me. I asked a haematologist, a neurologist, a respiratory physician, a cardiologist, an intensivist, and an emergency physician, how do you reverse thrombolysis? And they all came up with the same thing. Or we just throw the kitchen sink at them. Throw all the products you can and good luck to you. Not much works. Oh, no, I'm not happy here. All I'm left with is a big, fat pile of questions. And so I started to read, and I performed a literature review, some of which I'm going to take the opportunity to present to you today. Because the thing is, the more I read, the more I realised not only do we not know how to reverse the effects of thrombolysis, but we also don't even really know how TPA works. And not only that, we hardly even understand that coagulation fibrinolysis system. So I'm madly working away, and around that time I go to the museum. I go on the pretense of taking my 12-year-old son there, but actually because I really, really love dinosaurs. And I'm there at the museum, and there's this T-Rex bones there just, you know, on the floor somewhere, and there's a plaque next to it. And on the plaque says, on this bone, there's evidence of clot. And I'm, oh my God, 200 million years ago, we were clotting. And if we were clotting, gee, I'm really confused because I hadn't even considered how old this whole clotting system is as I'm trying to understand it. I think, God, how far back am I going to have to go to really understand coagulation so I can come back and understand what we do to it? So, look, as Carl Sagan said, if you want to bake an apple pie from scratch, you must first invent the universe. So I had to learn about how clotting evolved, and this is getting out of hand. And then what I discovered, what's fascinating about the evolution of clotting, is that it is held up as an example, along with the human eye, by creationists as an example that evolution cannot possibly exist, because it is an example of something called irreducible complexity, meaning a system, a biological system so complex that if you take away one part, the whole system can't work. So it had to be presented holus bolus. You couldn't just have, it couldn't sort of evolve over time. Oh, there's my thing, my religious take on that. This, of course, is complete bollocks, and there's lots and lots of wonderful bits of evidence that show us how clotting and fibrinolysis evolved, which are completely beyond the scope of this talk, but very, very happy. If anyone buys me a drink, we can talk about it later. But one of the great pieces of evidence comes back to our old mate, the lobster, who was a very, very distant archaeological relative of ours, evolutionary even, not even archaeological unless you start digging them up as well. So he's very distant relative, but he has managed to evolve his very own fibrinogen that works exactly the same, but it's come from a completely different protein called vitellogenin, which is actually a yolk protein, which is very, very cool. It's left us here. This is how we teach the clotting fibrinolysis sort of connection. We all know that. This is where you learn this at med school. This is ridiculously, preposterously oversimplified. Really, it's much more of a vast, swirling concatenation of this combination. It is so complex. It is not just those proteases that we all learn about, those nice cascades. It is cellular, endothelial. There are amplifications, dampenings. There are positive feedback loops, negative feedback loops. The clotting cascade has effects on numerous, myriad, almost countless other cascades in the body. It is so utterly complex, and into it we bring this baby. This dude is recombinant TPA, very similar to our endogenous TPA. You all know, you can all remember how TPA works. It activates plasminogen to form plasma, and plasma then dissolves the ropey fibrin, the fibres around a clot, usually in about 3 to 6 days. That's all very lovely, and the clot just, goes away. That's all nice. But the thing is, I reckon, if you actually asked TPA, it would be highly insulted that it was given this name, because TPA is what is known. You don't have to read that, I just did that for a joke. Actually, that's all the things that you need to know about TPA, which we can also talk about later. But TPA is a highly pleiotropic molecule, meaning it has many, many, many functions, including which are stimulating these matrix metalloproteinases, which cause breakdown of the blood-brain barrier, causes extracellular proteolysis. It's vasoactive. It actually causes vasoconstriction. It has all these effects on exocytotoxic neurotransmission, and it also has an extensive role in neuronal remodelling, and certainly in embryos in later life. And we have no idea what role all of these things play, because we're only finding them out in animal models. So let's just try and understand that whole clotting, fibrinolysis, concatenation a little bit better, maybe by thinking about as a Regency dance. So in a normal situation, it's very cultured, genteel, things happen at the right time, we clot, in 3 to 6 days, TPA comes in, does its bit and leaves, and that's how it should work. But when we give TPA, basically we pour this souped up, narcissistic brute on steroids, this recombinant TPA, and things go to hell in a handbag. And within 3 to 6 hours, there's this massive, not only fibrinolysis, and I'm a bit cross because I was taught that TPA is fibrin specific. That's just rubbish too. It's not, it's fibrin a little bit selective, but not specific. So you get this interesting thing called early fibrinogen degradation coagulopathy, fairly newly coined, fascinating. And then the whole clotting system, that massive Van Gogh swirl, is just things trying to catch up once you've done this. Absolutely fascinating. But I've been skirting around the main topic here, or the elephant in the room, if you like, which is using TPA in strokes. Because one certainly would think that if it wasn't for the cerebral hemorrhages that we cause by giving thrombolysis, we wouldn't care that TPA does pretty much not much. I won't say any swear words because I, unlike others, have read the code of conduct. Thanks very much. We wouldn't care that TPA doesn't do very much in strokes if it didn't cause this horrendous complication. 6 to 8% of patients get cerebral hemorrhages and there is no coming back from it. It's terrible. And that may not sound like a lot of numbers, but if it's something that you've done, then those numbers are much more important. Just now I'm going to argue with myself just for a moment. We don't actually know that it's the TPA that's causing these patients to have these intracranial hemorrhages, because we know that when we reperfuse anoxic brain, it's highly at risk of bleeding anyway, and we know that mechanical thrombectomies cause almost as many intracranial hemorrhages without the TPA. Some have, some haven't. So there's stuff going on. We don't know how much TPA badness is going on. But let me briefly summarise the evidence of how much we know about the reversal of the effects of thrombolysis. One is that I mentioned before, we don't even know what TPA does. Two, now this is the only bit of evidence, it seems as though the patients who have the greatest drop in their fibrinogen level after TPA are the ones that bleed. It's the only solid piece of evidence we've got. Don't know if that's causal or correlative, but that's what we've got. It's not the nadir of their fibrinogen level, it's the biggest drop. 3, when we look at all the retrospective, the observational studies that look at who does what to try and reverse the effects of thrombolysis in intracranial hemorrhage, it is a dog's breakfast. Everybody's doing something completely different. There's no consensus at all. And number 4, there is no one agent that seems to make a difference. So very briefly, what is in our sort of guidelines at the moment? This baby, cryoprecipitate, is probably the best chance we've got of doing anything based on simple biological plausibility. We in the colonies sadly don't get the lovely fibrinogen concentrate. That's not for us. So we get this martini of fibrinogen, fibronectin, factor 13, factor 8, von Willebrand's factor, and a few other secret ingredients. We don't even know what's in it. But anyway, we do know it has fibrinogen, and so the consensus is if your fibrinogen is low with a bleed, give the damn stuff. Tranexamic acid, don't think I haven't practiced pronouncing that a number of times so I don't end up on somebody's comedy video compilation video. You all remember tranexamic acid is a lysine analogue, basically does the opposite, stops plasminogen from being activated. Really, the thing that's already happened, that plasminogen's been activated, it, funnily enough, probably doesn't have any role at all, despite the fact that it sounds like a good idea. We just revert back to that academically cachectic argument that says, well, it doesn't cost very much, doesn't do much harm, I might as well just give it. So it just gets put in there anyway. Now, this baby, platelets, very surprisingly, has quite a great deal of biological rationale for using. This thing is a plushie, a platelet plushie. Did you know that you can buy the entire cell line in soft, furry toys? Please don't let it be said that I don't teach you anything. So you know. Anyway, platelets, because there's a very, very complex way that platelets become activated and become dysfunctional after TPA because of all the downstream effects. Having said that, of course, the patch trial has recently come out, which has told us that in the setting of intracranial hemorrhage, if people are on antiplatelet agents, the platelets don't make a damn squat difference anyway. FFP, the T, I realise I'm out of time, so my voice is going to speed up. I've only got a few more slides. FFP, weak T. The good thing about it is there's just not enough factors in there to make a difference at all. So if it's in the, it probably has no role. Whereas prothrombin-X, we have 3-factor prothrombin-X. I think a lot of people have 4 factors. We've got 2, 9, and 10. You can actually give enough of the, because when you think about it, we haven't touched the factors. The factors have been blameless. They've done nothing. With giving the TPA is all at the very end. So that you can soup up, you can increase the factors so much by giving inappropriate amounts of prothrombin, so you can make them clot in all other unhappy places that people don't want to clot. We won't talk about the Chuck Norris of clotting factors. So I need to finish up because I'm going to get in trouble, aren't I? Yes, I am. So I guess when one asks a singular question like this in biology, one sort of comes out because I either know an incredible amount or I know absolutely nothing. And I'm not sure here. And I'm going to end like most talks and we talk about the future. And what is the future? I think the future of thrombolysis in strokes is that we won't be looking for agents that reverse thrombolysis better. We'll be looking for agents that actually are able to remove the clot from the stroke without causing bleeding and having the problems with reperfusion. Why did I tell you about the evolution? Because I figure that medicine's not much without a whole lot of wonder. And it's all about the future. And if I can just finish with another David quote, it's a David Bowie quote, "Tomorrow belongs to those that hear it coming." So thank you very much for listening. Thank you. Sorry, we're out of time.
Awesome. Well, I don't think I've ever in my life enjoyed a talk on coagulation this much. Wow, as always, thanks. Do we have anything, Tim?
We do. We have obviously huge enthusiasm for this mix of dinosaurs, lobsters, your own personal self coming through as always, Michelle. A bit of hardcore science, different forms of TPA. And to have different effects on...
Yes, excellent question. I think, I'm a bit cross because I think we've been sold a bit of a dummy about the latest types of TPA or recombinant TPA. Obviously, we've got ultraplays, which we tend to use for strokes. The only thing that's been licensed is retoplays and then tenectoplays. All of them trying to get a longer half-life and more fibrin specificity. There's a whole lot of others that are hanging around, coming from vampire bats, etc. But none of they've all got the same problem with their reperfusion. I think it's going to be another different agent altogether.